Often we can take the hard work of the heart for granted. It beats constantly, moving blood throughout the body. But a vital part of the heart may develop a life-threatening problem. It's a problem called aortic stenosis, when the valve on the heart's main artery doesn't work the way it should. Joining us on today's Heart of the Matter to explain is Dr. Holger Salazar of the Stern Cardiovascular Foundation. Dr. Salazar, welcome to Heart of the Matter.
Thank you very much for having me here.
We're delighted to have you here on Smart Medicine. Let's go with some very basic information. What is aortic stenosis?
Very simply, it's a narrowing of the valve that the heart opens to inject blood to the rest of the body.
Okay, and what causes aortic stenosis and who develops this?
The main cause of aortic stenosis can be either congenital or it can be acquired later in life. Congenitally, approximately 1 to 2% of people that are born have what's called a bicuspid aortic valve, which means the valve that normally has 3 cusps only has 2 cusps. Second cause will be when you have a valve that is opening normally, but you have a membrane below the valve. That's called a subvalvular. And then when you have a membrane on top of the valve, despite of the valve opening fine, that's called a supravalvular aortic stenosis. Now, the most common cause of it is a degenerative type of aortic stenosis, which means that older people over time starts having calcification of the valve and doesn't open well anymore.
What symptoms can aortic stenosis provoke?
The main symptom usually is having shortness of breath with activities. Several people don't have any symptoms, but when you start testing how far they can go, they are limited and they recognize their symptoms. Now, when you start getting short of breath, unfortunately, the prognosis is not too good because at 5 years, 50% of people can be dead if they're not treated. Second symptom is passing out. The third symptom is usually having chest pain. And the final thing in this natural history is to develop heart failure when the valve is not opening because the heart is not going to be able to pump adequately across the gate that's closed.
How do you diagnose this?
There are several ways, but the gold standard is to make diagnosis by echocardiography, which is an ultrasound of the heart that is able to tell you what is the size or the orifice of the valve, how bad it's closed, what is the cause that's causing this closure, and also tells you a little bit more about the pressure inside the heart and the lungs. Sometimes the echocardiography is not able to do adequately because the patient does not have good pictures. So then we go to what's called a cardiac catheterization, which is putting a catheter in the groin, going inside the heart and be able to measure the gradients, the difference in pressures, and also measure the actual size of the valve based on formulas. 70% of people that have aortic stenosis can also have blockages in the heart vessels that feed the heart, so the cardiac catheterization will help you to guide you through the treatment if the patient needs to have surgery, if also bypassing need to be done at the same time. Another tool that is helpful is MRI, which does exactly the same as ultrasound, but it costs more.
What is the treatment for aortic stenosis?
The treatment until 2 years ago probably was only surgery, which it can be done as a conventional open heart surgery, exposing the heart through the breastbone and replacing the valve either with a prosthetic mechanical valve or a bioprosthetic valve, which is made out of pig or cow. When you take the bioprosthetic valve, you don't need to take anticoagulation with coumarin, and when you take the mechanical valves, you have to be committed for them for life. Duration of the life of the valves now are about the same in our days. But over the last 2 years, we have had a lot of reports about doing this replacement through a percutaneous technique, in other words, without having open heart surgery. And this is already approved in Europe, and it's been done in several centers in the United States under studies. And the way to do this very quickly is in 2 manners. One, it can be a mini surgery, which you just expose a little bit the tip of the heart, and then you go in with a catheter. At the same time, the patient anesthetized momentarily, and you deploy the valve while the heart is not beating. And you do that with a team of an anesthesiologist, an echocardiographer, and a surgeon. The next way that this can be done, or the other way that this can be done, is going through the groin through a normal catheterization, which you have to do a cut down because the catheter is too thick. So you have to open up a little bit the groin, expose the artery, and then go inside in a retrograde fashion, deploy the valve, and you call it a day. Now, studies have been shown right now in Europe at 2 years that the duration of this valve is pretty good, and they're still working at 2 years, but we don't know long term. So I think probably within the next year, we're going to see this done more often in the United States.
All right, Dr. Salazar, thank you for joining us here on Heart of the Matter today.
Thank you so much.